We'll start now the pediatric dermatology session, and it will be a great pleasure to introduce one of the best pediatric dermatologists in the region. So it's my pleasure to introduce Dr. Arti Nananda, who is the head of pediatric dermatology and consultant in charge of the rare skin disease at Asad Al Hamad Dermatology Center in Kuwait, with over 30 years of clinical research and teaching experience. And she has been Secretary General of International Society of Pediatric Dermatology since 2021 and served as an Executive Board Director, Chair of the Communication Committee, and Chief Editor of the Online Education for ISPD since 2019. Dr. Nananda is a member of AADV Task Force on Pediatric Dermatology and Autoimmune Blistering Disorder, and part of the project developing guidelines for pediatric mycosis fungoides. And she is the editorial board of Pediatric Dermatology with different journals, and she is a fellow of Royal College of Physicians, Edinburgh, and she is an active member of numerous international societies, including AAD, BAD, AADV, and different society. And she has been an invited speaker and the chair and co-chair for international conferences since 2003. And in recognition of her leadership in pediatric dermatology, Dr. Nananda received 2021 ILDS Certificates of Appreciation for International Leadership in Pediatric Dermatology. It's my pleasure to introduce you, and the floor is yours for your session.
Thank you, Chairman. It's nice for this kind introduction. I'm obliged. And thank you, Dr. Muhammad, for your kind invitation. Your scientific committee, your organizing committee, it's a pleasure to be here in this conference. Starting with my presentation on pediatric emergencies, lessons that I have learned in my practice. I have no conflicts of interest to be announced. Starting with my first case, we were asked to see this baby when she was 1 day old by our pediatric neonatal ICU, and she was delivered at 30 weeks due to placenta previa, antepartum hemorrhage, and oligohydramnios in the mother, and then the birth weight was very low, 925 grams. Baby was noticed to have congenital absence of the skin. The skin was very fragile, and there were widespread erosions. Also had anonychia of all the nails, rudimentary ears, and rudimentary nose. It was first born to consanguineous parents. This is the family pedigree. As we see here, the baby the parents are first cousins, and father at the time of baby's delivery was just 21 years old, and mother was 19 years old, and the first baby. This is the larger view of this baby. As we see here, congenital absence of the skins on the legs, on the arms, half of the face almost, multiple erosions on the skin of the trunk because of the skin fragility. Wherever the sisters were, whenever they were handling, wherever they were touching, the baby was getting peeled off. And this is the back of the baby. And other views, as we see, the ears are almost very rudimentary, nose is rudimentary, and no nails at all. Our clinical impression at that for this baby was epidermolysis bullosa, but the question was, which type? We thought most likely it's a case of junctional epidermolysis bullosa, because we know junctional can be, severe junctional can present badly, have bad course, and can be really complicated cases. But then also acantholytic type of epidermolysis bullosa simplex crossed the mind, because there are only few patients reported. It's a EB simplex variant due to desmoplakin mutations, and these babies usually die soon after birth. So it is some other rare variant. Ordinarily, when we have these patients, we start with a skin biopsy. Earlier, we used to do electron microscopy, but now we are not commonly doing electron microscopy because monoclonal antibodies against most of the genes identified for EB, they are available, and we do immunofluorescent antigen mapping as a screening test for these patients. But unfortunately for this patient, neither our surgical team nor the pediatric surgery people were keen to do a biopsy because baby was only 900 grams, and to a biopsy in the incubator, baby was on so many, on the IV lines and multiple complications, septicemia, so they were not feeling comfortable to do a biopsy and so much of fragility. So they did say, let the baby be stabilized and we might think of a biopsy. But unfortunately, what we were told by the NICU people, that this baby may not survive. It's very bad conditions and most likely going to succumb for the disease. So next question came, then should we go ahead straight with the genetic testing? So this was the option. So I contacted Professor John McGrath because he's the one who is affiliated with us. He's the one who is helping our patients of EB for their genetic diagnosis. And he told me, okay, no problem, send the samples and we'll try to screen straightway for the genetics of this baby. That was also an issue, but because there was no IV lines, but then when they put a central line for other investigations, they did collect some blood for our genetic testing also. So we immediately transferred the blood to UK, a national EB lab. And I got a message from John, Aarti, the samples which you have sent for genetic testing, they're all clotted. Oh, what to do? I told him, we are desperate. Baby is deteriorating day by day. I want some answer to give to this young couple who are so demoralized with the first baby and they want to have more pregnancies. So please help me in some way. So he passed the order to his laboratory chief technician. Please take it as a special baby. Try to find out whatever DNA you can extract from the clotted blood and do the test. And thank God, they could manage. We are thankful for their help. And we got the result. The baby shows homozygous pathogenic variant of integrin beta 4 gene, and both the parents are heterozygous carriers of this gene. So this is the pathogenic variant which is known to cause junctional EB with pyloric atresia. And this is a very serious presentation again. Most of these babies also die in the neonatal period or very early months of their life. But thank God we had the result. And our patient did not manifest with pyloric atresia features because the baby was only on IV lines and did not take anything orally. So that's why the GI symptoms were not present. That's why we did not think, although we knew it's one of the junctional as a top priority, but we did not really say which variant of junctional from that angle. So a baby died as was expected at the age of 2 weeks due to septicemia and septicemic shock. And we provided the reports to the parents. We gave the genetic counseling about the disease to them, and we referred them to our maternity center and genetic center for the possibility of pre-implantation genetic testing so that they can undergo IVF pregnancy and can have normal babies in future. So I will not talk, this is not the title of my presentation. I'll not discuss in detail about EB, but we know that EB is a heterogeneous group of disorders and 4 main groups and many subtypes under that. And then junctional, we know that most of the patients with junctional, they have a poor prognosis. But now, with our experience, we have also understood that there are at least 7 genes which are involved in the pathogenesis of junctional EB. And patients can be of mild and intermediate severity as well. But there is no shortcut to this disease without genetic testing, because that is the final diagnosis which can help us to provide the genetic counseling and explore the future possibilities of management and guidance in these patients, like in our patients. So I learned a lesson from this patient that even among amid the darkest situation, like we had in this baby, we are going to lose it, very critical, we still have a star as a hope for some counseling, something which we can offer to the parents and something which we can provide for the future. Coming to my second case, they are different genre. This is a baby who at the time I was consulted was 27 days old. It was a Friday. I got a call from our PQ that, Dr. Aarti, there is a patient who is just now presented to us. Baby is gasping. Baby has a large vascular nevus on the face, and we have to do the tracheostomy to save the life of the baby. And baby was earlier admitted in our pediatric ward as a case with a widespread port wine stain, and baby was asked to do MRI, and they discharged the baby, asking the parents, please come back to us with the MRI result. When I looked at the baby, this was the picture which was sent to me. I don't blame our pediatricians or any doctor who might think of port wine stain in this case in the beginning, because a flat lesion occupying half of the face, deep red in color. But I was not convinced with the overall course of the patient, so I told our doctor, no, to me it looks a hemangioma. So please give me the natural history of this baby. Ask the mother how the lesion started and what happened to the baby. So they came back to me after some time and sent me these pictures from the mother's phone. They said, this is how the baby was born. As we see, there is nothing, just some telangiectatic component on the face. And then mother also had another picture after 17 days, which we see now we have a lesion which is vascular. And even at this stage, I don't blame even our pediatricians if they thought it is port wine stain. But what was missing? The natural history of the disease. So we know that port wine stain is a capillary malformation, is a vascular malformation, and is present right from the birth as it is. It does not change in morphology, doesn't increase in size, and doesn't proliferate, which is the story of infantile hemangioma. And port wine stain, we are not worried for airways, but infantile hemangioma and dislocation is the one which was giving him airway symptoms to this baby. So I told them, please, you solved my problem immediately. Give this patient, start this patient on propranolol, and they started the patient on the proper dosing of propranolol, and also added some steroid for short period to prevent this, the airways inflammation and edema. Tracheostomy was already done, and other supportive treatment was there. So the other investigation which came back to us later, the urgently asked the baby had large airway hemangiomas occupying almost 2/3 of the airways. And baby MRI showed some cerebellar hyperplasia with vascular anomalies, and your ultrasound abdomen showed multiple hepatic hemangiomas. So final diagnosis is very clear now. Baby had face syndrome with airways hemangiomas. So this is the picture of the baby at time of presentation. And another thing which I felt was missed, looking at this lesion on the abdomen. If they had followed closely this baby, probably they would have earlier thought of hemangioma in this case. There's a lesion in the abdomen. And then this is the picture at presentation. This is the picture when I went to see the baby on 4th day, after 4 days of propranolol therapy, see the result. And this is the picture after 11 days of propranolol therapy, amazing results. And this is the picture at 11 months. The parents brought the baby to me before they were going to get the removal of tracheostomy tube done. So this is the interesting course of this case. The second patient I'm going to show you is, again, a similar kind, but not exactly, a patient which I was again consulted from our PQ. This baby was also admitted with them and was gasping. So this is the picture they forwarded me, that this baby is gasping. So my next, and then they told us when we did fiber optic laryngoscopy for this patient, this is the picture we got. Radiologist feels it's a tumorous mass, most likely vascular, but they're not sure it is hemangioma or not. So I went to see the baby. I asked them, can I examine the whole skin of the patient? Do you have any hemangiomatous component on the skin? They said no. But then, yes, the doctor on call remembered. But yes, in the morning, our nurse was telling us that when they were changing the nappy of the baby, there is something on the genital mucosa. And there is some growth in the genital mucosa. And although it was not typical hemangioma, but it was enough hint for me that it can be, say, hemangioma in the mucosal mucosa of the genitalia, and along with that, the baby also has airway hemangioma, which is not a usual presentation, but we need sometimes some clue of some sort. So baby was immediately, I told them before, and ENT surgeon, pediatric ENT surgeon was actually planning an urgent surgery for this baby to remove the tumor to save the life of this baby. I told them, wait for 1 or 2 days, start this baby on propranolol, and let's see what happens. And so this is the treatment which we started. And amazingly, the respiratory symptoms started to improve within 24 to 48 hours. And wow. And then these are the pictures. You see the difference? This is the tumor before starting the treatment, and this is after 3 weeks of propranolol. So sometimes small hints can serve as blessings. So this is another lesson which I learned, because normally we say hemangiomas in the airways. When we have head and neck hemangiomas, they are the more common. When we have mandibular hemangiomas, but here the story is different, which told you. And this is then fourth case, again a similar kind. I'll quickly pass it. Again the same story. They told me another baby has come to us gasping, and baby has some tumorous mass in the airways. And then by this time, our PQ team was very expert. They examined the baby as a whole. They found that baby has a hemangioma in the abdomen. Again, not the common teaching, not on head and neck area, but there was a hemangioma. So they told Dr. Hati, we are planning this baby to start on propranolol. Should we? I said, go ahead. And this is what they did, and baby was saved. And nothing else was required for this patient. So this is also pictures we got from mother at the time of birth, and then how the lesion had grown later on. So lessons that I learned from my first patient: keep a hope in the worst scenario. We may still have something to offer to our patient or to the family. For my second patient, when we have atypical presentations and we are clinically suspecting hemangiomas, a natural history is very important. Please never ignore asking parents how the lesion started. And the last case is, common is not always common. We usually say in the medicine, common is common. But please, exceptions exist. Be vigilant and be alert. And before I finish my presentation, I'd like to invite all of you, please come and join us in Kuwait for our upcoming Kuwait Society of Dermatology conference. Our chairman has chalked out a very interesting program, and we look forward to seeing you there. It is next month, 6th to 8th of February. And then get tuned to 15th World Congress of Pediatric Dermatology in Buenos Aires, Argentina, which is going to be in April. And then last but not the least, being the part of International Society of Pediatric Dermatology, I invite all of you, if you are already not, please come and become our members and join our 1,400, more than 1,400 actually, international members of this society, and avail our educational activities, which we are offering, a lot of educational activities we are offering in this society. And the registration is free so far.
Thank you,
I want
Dr.
to finish my presentation with a very quick,
Thank you, Dr.
very quick
Nadar.
quote: "Let the eye of vigilance never be closed." Thank you.
Thank you. Now the second session is with Dr. Abdullah Al-Akil. He is Associate Professor and Consultant, the Department of Dermatology, College of Medicine, King Saud University, and he's the President of Saudi Society of Dermatology and Dermatologic Surgery. Welcome, Doctor. تفضل.
Assalamu alaikum jami'an. Thank you for this very kind introduction, and thank you, Dr. Mohammed, for this invitation to the fourth version of the RIDV. It's not my first time here. It's not going to be the last, hopefully. And I was asked to present some interesting and challenging cases from my clinic. So let's start. It's going to be only 5 cases, and it might be a bit interactive, if you may. Let's go. How does this go? Okay. So let's start. The first case is a 14-year-old female with no previous medical history. And she presented with lesions that were associated with frequent itching, not much. She tried topical ointments, but only partially elevated. And On examination, this is what we saw. Very well demarcated annular plaques. The edges are a bit raised in comparison to the mid. It's a bit flat in the middle. What do you think this is? Do we have juniors here? And then residents هنا ولا لا؟ ما في? So what do you think this is? لا انتوا لا. لا. What do you think this is? انتوا شايفينها قبل ها؟ Bravo, porokeratosis. So this is mostly porokeratosis. And so just to go fully, the patient denied having any specific lesions or triggers. We asked about everything: atopic dermatitis, asthma, food allergies, and joint pain, and she had nothing of those. Apart from topical emollients, she had no previous treatment. أنا كنت في الرياض. She was outside Riyadh, and she only applied emollients, and she was very, very bothered. She's 14 years old. It doesn't look nice. She wants to dress and stuff. So it doesn't look like. So the challenging part is what shall we do in such cases? First of all, we did a biopsy to prove it, and it came back porokeratosis. As for all of you to know, just briefly, it's an epidermal keratinization. What is the most thing that we always fear in such cases? Sorry? Bravo. What's your name? Bravo. SCC. So that's what we, first of all, we try to our best to look for. So it can be diagnosed through histological examination, and we see the cornoid lamella. طبعا cornoid lamella مش بالضرورة, it's not necessarily only for porokeratosis. So we should always make the confrontation between histology and the clinically. لأن cornoid lamella ممكن يكون فيها أشياء كثيرة. So yes, it's written here. So it's not considered pathognomonic, and it's found in various inflammatory and neoplastic skin pathologies. بس لما نشوفها cornoid lamella ونشكين porokeratosis, just make the confrontation between the two. So there are types of it, but as we said, the risk of squamous cell carcinoma, and to a lesser extent basal cell carcinoma. Ultraviolet has been shown to exacerbate the symptoms of it and promotes the neoplastic transformation. An accurate diagnosis is very critical to receive the best possible treatment. Now the treatment is a bit the challenge. So I started her on isotretinoin, 20 milligrams, once a day. Nothing much happened. So only for the itchiness that she reported that was a bit improved. Upon re-examination, after a couple of months, she improved in terms of the central erythema. There was no observed difference in rash size or the peripheral scale thickness. So the peripheral scale thickness was the same. Erythema was a bit improved, and the itchiness improved. So not that much. So in conjunction with isotretinoin, what I started to give is atorvastatin ointment. There were some studies about that. I did twice daily. So 10 weeks later, at the follow-up appointment, the itching did not change. It was already improved, yani. And unlike the peripheral scales and pigmentation improved, but by a small margin. يعني ما في التحسن المطلوب يعني. But still, it did improve. So in general, retinoids taken at dosage of 20 milligram for about 4 to 5 months is regard the first-line treatment. Despite this, less than 20% of patients who receive proper treatment achieve complete resolution. It's not in my patient. The mechanism by which retinoids affect the keratinization is complex, but simply put, يعني باختصار, the retinoids are thought to interfere with the differentiation of the keratinocytes. So it's still debatable in the literature whether topical statins are beneficial to patients with LP. يقولون يعني, is it really beneficial? The improvement was from the cream itself, or from the vehicle itself. The cream itself could be a bit helpful ولا من atorvastatin. So it's still debatable, but few studies that have satisfactory results. If administered at the start of the treatment, I started it a bit late, so could be a factor of it not working. It would be better evaluate effectiveness of topical statins when paired with isotretinoin. So it's still a bit challenging, and we did publish this study. So we might start. It's still very challenging. We still give isotretinoin, but the thing is that we should start giving it at the beginning. Atorvastatin, isotretinoin, we will see. It was some satisfactory results. Not in my patient. It resulted a bit, but not that much. So I think we still need more. What did I do? Okay, this is a case number 2. An 8-year-old boy presented with a slowly growing lesion over his right ankle, which he had since birth, and was asymptomatic. It doesn't look nice. It looks bumpy a bit. A biopsy was taken. What do you think this is? Let's see the biopsy. We have hyperkeratosis of the epidermis, we have infiltration of the dermis, and we have fat cells and some, approximately 70% of the dermis. So what do you think this is? Who has any idea? It's a bit complicated. No? Sorry? Okay. I'm happy. Bravo. The thing is that this is a hairy nevus lipomatosis, cutaneous superficialis. It's a long name. It's hairy, mostly. So we know that there's nevus lipomatosis superficialis, but the difference here is that this is hairy. Okay? So this is a bit unique in this case. So when we thought about it, when I saw it, I said, this is nevus lipomatosis, but it's weird because it has some hair, and I went back reading, and then we found very few cases similar to this case. So it's a rare idiopathic hamartoma. It's characterized by two entities. واحدة اسمها classic form and the solitary form. Our patient was the classic form. You can nodules, the smooth cribriform surfaces, and mostly on the lower limbs. A solitary type يكون واحدة غالبا at the later ages of the patient. Type. So in our patient, the onset of the lesion, the site, and the clinical appearance were consistent with the classic form. And the difference here is that, however, the presence of hypertrichosis in our patient is a unique feature. The best to our knowledge, this feature has been reported only once. So we did report this case, as we can see here, for the American Journal. Case number 3, and this was a nice one. This female presented to me with pigmentation on the half of the face. And on examination, and on examination, I saw this well-defined light brown patch on the right side of the face with hypertrichosis. في شوية شعر, pigmentation مع شوية شعر. And I looked to the teeth, I looked at the teeth, and she had the same size, a unilateral, you can see here, a gingival and lip hypertrophy. حتى the lip can't feel some hypertrophy over the right side. In addition to irregular spacing of the teeth of the same side. It was weird to me a bit. What I did is I took a biopsy to see exactly what is it. It's because I thought at the beginning, what do you think when you see this at the beginning? Like just a pigmentation with hypertrichosis? Becker's, صح? Becker's. When you see a Becker's nevus, and along with hypertrophy of the lip, along with, there's something more than just Becker's nevus. I did take a biopsy, and the biopsy came back suggestive of Becker's nevus. I did a panoramic dental X-ray, and it shows hyperplasia of the right maxilla. So there is some sort of hyperplasia. It's not just that I felt it. There's something going on, as we can see here. This is something called HAT syndrome. I knew it when I was just checking for it. So HAT syndrome is a hemimaxillary enlargement, asymmetry of the face, tooth abnormalities, and skin findings, and is considered a rare developmental disorder involving the first and second branchial arches. So Becker's nevus يكون أكثر شيء يكون ملفت فيها Becker's nevus, and it's apparent at birth or during early childhood. Males more than females, and between 2 and 28 years of age. So there are some studies about it here. It's not that much, but you can see some studies, and يكون لها وقت من زمان موجودة. So the etiology of a HAT is not known. It's a segmental localization of the abnormality suggests a local developmental defect. So absence of one or both premolars and early manifestations in such cases. There's a similar post-zygotic mutations زي ما نشوف في Albright as well. So it's some sort of mosaicism اللي قاعد يقولون عنها, mostly some sort of mosaicism. So the type of post-zygotic mutations in patients with HATs may result in genotypic and mosaicism in both bone and skin. So that's mostly what we see. What shall we do in such cases? Nothing much, mostly lasers for Becker's nevus, but we can involve the team of the dental team as well. We can involve them to be with us. So treatments to do to date include combined surgical and orthodontal treatment for eruptive teeth. Becker's nevus are reported to be successful with treated with Q-switch ruby laser. Erbium, you try your best, but that's mostly it. So, and we did, of course, as well publish this case as well. Now this one. So this case is interesting as well. It's a 4-year-old child born to parents related by first-degree consanguinity. Presented, the mother came to me complaining because, simply put, لونها تغير. تقولي بس كذا بكل بساطة لون البنت تغير ما كان لونها كذا. She changed. Her color changed. They started looking at this by the oral hyperpigmentation. Started very, very early. She's 4 years old. Started at 1.5 years with progressively diffused acquired melanoderma, as well as a long-standing dry eye syndrome. طب جت ورتني صور، كانت توريني صور لها، تقول لي هذه صورتها قبل، هذه صورتها بعد، هذه صورتها. What is this? وفعلا كانت لونها فاتح. She had a fair skin, and when I saw her, she had a very dark skin. Not a very dark skin, but much darker than the photos. So you can see as like here. So on examination, you can see the tongue, all the buccal mucosa, the folds. You can see they are dark. The skin is a bit dark. So, what do you think this is? اسم صح. What do you think? يعني الكومبلين لما يجيك أحد يقول لك والله أنا كان لوني وتغيرت. For children. Huh? Yes, Addison. So we thought about Addison disease. I went doing some labs. So lab tests confirmed low adrenal insufficiency. بس المشكلة كانت it's not only Addison. في عندنا dry she had some dry syndrome. So she had a combination of alacremia, adrenal insufficiency. So we went screening for something called Algrove syndrome. Okay, I went through genetic testing, and the mutation was unique, and it came back for Aladdin protein. So this was something called Algrove syndrome. Both parents were heterozygous for the same mutation. And of course, I had to do a genoscopy because we should do it in such cases. Was done once the diagnosis and it was negative. Alhamdulillah, في البداية قلنا okay. 2 years later, the onset of vomiting raised concern about this. I did it again, the second EGD, and esophageal manometry, and it came back a bit positive. The child received symptomatic treatment consistent of some hydrocortisone and esophageal dilatation, and she's doing fine for now. But as you can see, I did publish the study as well. The fifth and the last case, it's a case. It's a bit. I just feel bad about this case because I missed it at the beginning, so I don't feel good about this. It was last summer. So this patient came to me with his mother last summer. I had a very full clinic at the hospital, and she came complaining because she said that her son is having multiple bruises. And when I asked how long was it, she said about 3-4 months. I was like, bruises 3-4 months is a bit weird. And on examination, he had this bluish discoloration here and there. And first, it was really bluish. And so I was thinking of maybe some abuse, and we had a full clinic, and my residents all the way says, look at this, you know what, just do some labs, that he might be having some, whatever, platelet, whatever, blood dysfunction. Just let's focus on any abuse, maybe at home. I gave them 2-3 months appointment, and then they came back. And the same lesions were there, with new lesions. So this is not a bruise. Bruise should have been gone for now. And at that time, I was like, no, this is something wrong. I missed something. Now I should sit down. I got that boy and حطيته قدام الشباك كده. And what I noticed, if you can see here, some of them, the edges, if you can see maybe. حاولت قد ما أقدر أجيب صورة كويسة. في some sort of atrophy that I couldn't detect في البداية when I was a bit fast. So what do you think this is? Morphea. Simple morphea. And I was like, oh, how did I miss this at the beginning? So morphea, because it was bluish in a way, and really on the flanks, you can see the photos here, في الجنب في البداية. I really thought, and he used to play a lot of soccer as well. a lot of football. فقلت يمكن قاعد يطيح يمكن. But when I really did take my time in examination, it was very clear at the back with that, some atrophy there. I did a biopsy as well. It came back with morphia. And inflammatory markers were normal because it's only a cutaneous inflammatory disease. ANA and anti-SCL negative. He's on topicals for now. Everything is fine. He's controlled, and it was just a lesson for me and the residents that you should always take your time. Don't be overconfident. So that's it. So thank you very much.
Thank you, Dr. Abdulaziz. Abdullah. شكرا دكتور عبد الله.
So we will listen again to Dr. Artin Ananda. So she will give us another lecture. Welcome back.
Thank you so much. Good afternoon again. I hope you're still awake after lunch. So my second presentation, Pediatric Connective Tissue Disorders, pearls from my experience. I have no conflicts of interest involved here also. Starting with the first patient, she's now 20 plus, but when I saw her first, she was 9 years old, and she presented to us with recurrent asymptomatic papillonodular eruption on the face of 1 year duration, and which was followed by atrophic scars, and she also had hyperpigmentation as a remnant of that. There was no history of preceding infection, drug intake, or other preceding factors. There was no history of associated arthralgia, myalgia, fever, fatigue, etc. Her past family history was irrelevant. And these are the pictures of the face. As we see here, she shows erythematous, papules and nodules scattered. She also has some atrophies and PIH with mild atrophy in different parts of her face. Closer view of the forehead and upper face showing similar findings, and sides of the face also showing similar findings, and this is her biopsy mark. A skin biopsy for histopathology, this is in lower magnification, we see that the patient shows here periappendageal inflammatory infiltrate, perivascular infiltrate, and also lobular paniculitis. This is the closer view, shows vacuolar alteration of the basal cells, and then this is the deeper part, which shows dense inflammatory cell infiltrate in the fat lobules, and also eosinophilic hyaline material around the fat cyst, leading to hyaline degeneration of the fat cells. So direct immunofluorescence showed granular deposition of IgM at the dermoepidermal junction, and then we did, based on these findings, we proceeded with other investigations. She had borderline leukopenia with neutropenia, and she also had positive ANA up to 1:60 with speckled pattern, but she had low borderline C4, but most of other workup was grossly normal, except for some high TSH for the thyroid functions. Based on our clinical, histopathological, and immunological parameters, we diagnosed this patient to be a case of lupus profundus. Patient was started on hydroxychloroquine, 200 milligrams, and was increased to 400 milligrams for a better response. And topical tacrolimus was, I'm sorry. The topical tacrolimus was added, and patient showed a very good response. The only problem with her was little non-compliance. When she improved, she'll disappear. She will lower the dose on her own, or sometime we will stop and then come back to us with mild recurrences again, and we'll restart the treatment, try to convince her, please don't stop on your own. So she came back to us after 4 years. This again, which shows that she had excellent improvement following hydroxychloroquine and just some PIH and some mild atrophy which was remaining on the face. But this time, she told us that I stopped treatment more than 1 year back, and during this time, I did not get any skin lesions. But now I'm getting vague arthralgias. generalized arthralgias. We did the collagen workup again. The only positive findings was high titer ANA again, but higher than the previous value, and she also still had persistent leukopenia and neutropenia. We referred the patient to rheumatologist for evaluation, but again, she disappeared. She did not come back to us with a follow-up, and despite our reminders, she will not show up. Her mother had some issues, and they did not show up. She came back to us 4 years later with some generalized skin rash. And this time, she tells us that 2 years back, rheumatologist diagnosed her to be a case of mixed connective tissue disease based on previous history of lupus profundus, positive antinuclear antibodies, leukopenia, neutropenia, arthralgias which were persisting, and restrictive lung disease on investigation. She also had decreased pulmonary function test and also lung fibrosis. She was started by the rheumatologist on a combination of prednisolone and mycophenolate mofetil CellCept. And steroids were tapered off slowly, and she was maintained on 1 gram of mycophenolate mofetil. When she came to us, she was still taking 1 gram of CellCept, and this was the picture of her at that time presentation. When we looked at the lesion, she has multiple guttate lesions on the face, on the trunk, with hyperpigmentation and superficial atrophy on the scattered on the trunk. And we did 2 skin biopsies for her. Both the biopsies showed the similar features. When we look at here, we thought that she is a patient of anatoderma with SLE, because we know anatodermas are very common in SLE patients. Our clinical impression was that. But when we did the biopsy, surprisingly, as we see here, she shows a diffuse homogenization of the collagen bundles all through the dermis, and thinning of the epidermis, which of course reflected the thinning or atrophy of her skin. And here's a closer view. We see the homogenization of the collagen bundles, and she also has perivascular periorinic cell, mixed inflammatory cell infiltrate. So we proceeded with the collagen workup again. In her case, this time she has leukopenia with neutropenia. She has increased ESR, which was not there before. She has more high ANA with the speckle pattern, and she also has ENA, anti-Smith and anti-U1 RNP antibodies also positive. And she had low C3, but C4 was grossly normal, reduced pulmonary function test, and fibrosis in the chest on CT chest, and very high CPK in her blood. But she didn't have any myopathic symptoms, but if you remember the pictures, that stage she was showing wasting, and she had muscle wasting, but no obvious myopathy. So we diagnosed her. Now, of course, she's a full-blown picture, but we diagnosed her lupus profundus, gutted morphia. This type of morphia has been very rarely reported in the literature. Gutted-like lesion, but histopathology is one of the variant of morphia. Atrophoderma-like morphia, they called it. Restrictive lung disease, supported by hematological parameters, immunological, very high ANA, and anti-U1 RNP antibodies, which are specific for mixed connective tissue disease. They are seen in SLE patients, but when patients do not fulfill the criteria for SLE, this is a very important test for mixed connective tissue disease also, and very high CPK. So then this patient was started, we talked to our rheumatologist, and they increased the dose of steroid, increased the dose of CellCept, and patient showed very good response to this treatment. This is 4 months later, 5 months later, when she came back to us. Most of the lesions had subsided with PIH and just mild atrophy. And she continues to be under follow-up of a rheumatologist. So just to brief you about this case, lupus paniculitis is a rare variant of chronic lupus erythematosus. Usually tender or painful nodules, but rarely can be asymptomatic like our patient. More common in females, rare in children, but all ages have been reported. Accounts for, in well-established SLE patients, 2 to 3% of those patients can have lupus profundus lesions. But when we're talking about lupus profundus in relation to SLE, in most patients, SLE predates, or they both happen concomitantly, 65%. But in some patients, lupus profundus or lupus paniculitis predates, and then subsequently they develop SLE. Rarely they can be also not only SLE, they can be just in association with discoid LE or systemic sclerosis, some reports are there. Treatment, by the choice treatment is hydroxychloroquine, but in case it doesn't work, methotrexate, other immunosuppressants have been tried. In patient going on to systemic phase, steroids have been used, and for resistant cases, IV immunoglobulins and rituximab. And then I just came across, because now we are talking in the era of biologic targeted therapies, we have one of the targeted therapy, anifrolumab, which is monoclonal antibody that binds to subunit of type 1 interferon receptors and is already FDA approved from 5 years onward for SLE. And there is a report that it was used for resistant LP patient and showed the good response. And then when we have only from as a dermatologist pure LP, we tell our patient you have 20% plus risk of going on to systemic disease. And there are rare reports of developing dermatomyositis. None of the patients I came across which progressed onto mixed connective tissue disease, but that just, there has to be first patient always. And then atrophoderma, I already told you, is a very rare variant. And mixed connective tissue actually is considered by many to be a separate entity. Just where the combination, it was proposed in 1972, but then many diagnostic criteria were given. It's a combination of SLE, systemic sclerosis, polymyositis with high titers of anti-U1 RNP antibodies in these patients. Our patient is unique in many ways. Didn't have frank SLE, but had mixed connective tissue disease with lupus paniculitis or lupus profundus, atrophoderma-like gutted morphia, not systemic sclerosis, but then some features suggesting of systemic sclerosis like restrictive lung disease, and not frank dermatomyositis, but very high CPK enzyme, also reflecting some muscle disease, and positive U1 RNP antibodies. So this is a longer case. Second patient will not take long time, but also one of the interesting cases from our record. This patient is now actually 27 years, but was first seen by us at the age of 16 years. And she presented to us with progressive vesicobullous lesions on the face, trunk, and extremities of 2 weeks duration. She had painful oral ulcers. Past medical history was that she was suffering with recurrent attacks of urticaria since last 2 years. She had been also having fever on and off, and one time she had fever with lymphadenopathy, was hospitalized, but lymph node biopsy was just reactive, and her family history was irrelevant, and these were the skin lesions at time of presentation to us, widespread vesicobullous lesions. And she also had oral ulcers, painful oral ulcers, and the other picture, and on the base of urticated plaques. So this is something which is very interesting, and then palmar erythemas. So we did a skin biopsy for histopathology. As you see here, it shows a subepidermal blister and vacuolar alteration of the basal cells. Direct immunofluorescence, positive for granular deposition of IgM at the dermoepidermal junction. Indirect immunofluorescence for salt splitting shows immunoreactant at the base of the blister. And so we further investigated, because I know by now you have clue what was our diagnosis this patient, so we further investigated. She had pancytopenia, leukopenia, anemia, and thrombocytopenia. She had very high ESR. She had proteins and RBCs in the urine. She had very high antinuclear antibodies, positive double-stranded DNA and ENA with anti-Rho, anti-LAR, anti-Smith antibodies. And 24 hours urine also shows proteinuria, and she had also decreased complements. So full-blown picture of systemic lupus erythematosus. So we diagnosed her to be a case of bullous systemic lupus erythematosus. The patient, we know is a rare entity. It's considered to be a variant of subacute cutaneous lupus or even SLE spectrum, and 0.19 to 41% of the patients with SLE at some stage do have bullous lesion to label them as bullous SLE patients. And from dermatological point of view, please remember, whenever you have bullous SLE, most, I must say 100%, but if not at that time, most of these patients fulfill the criteria of systemic lupus. And most patients have antibodies against collagen 7 or a few against laminin 5 or BP antigen 1 also. The treatment of choice mostly is Dapsone. But then if resistant cases or Dapsone cannot be given, methotrexate can be used. But if patient is very aggressive and rapidly progressive, better to start on steroids and some other strong immunosuppressant to give a better control of disease. And then there are other therapies, and for resistant cases, IVIGs and rituximab has been used. And again, to talk about a new drug, there I came across a report. This is another new biologic, belimumab, which is a humanized monoclonal antibody which targets B lymphocyte stimulator. It's an inhibitor for that. And is also FDA approved for SLE and was recently tried for bullous SLE patient also, so can be one of the potential treatment. And we started our patient, because that time these drugs were, we started our patient with the prednisone, mycophenolate methylene and IVIG, because course was very aggressive in her case, and she was going on with some urticaria, lymphadenopathies, fever for since 2 years, so we wanted to be aggressive to control her disease. And these are the pictures after treatment. And she did very well. Now, 12 years after, she continues to be in remission. So again, I invite all of you to Quest Society Dermatology meeting next month, to World Congress of Pediatric Dermatology in April, and become the member of the ISPD. And I want to finish saying, life is full of colors. We never stop learning. Thank you very much.
Thank you, Dr. Arti. We will keep the question until the end of the session. Now it is my pleasure to invite Dr. Marco to tell us about his experience in managing mycosis fungoides in children. He is a dermatologist, pediatric dermatologist, and dermatopathologist, and head of department at KK Women's Children Hospital, and visiting consultant at Singapore General Hospital. He is the president of International Society of Pediatric Dermatology. Welcome, and the floor is yours.
Thank you, Dr. Fatima, for the kind introductions, and thank you for staying for these pediatric dermatology sessions. Usually, I find that somehow attendance at pediatric dermatology sessions are usually not as good as when there's a cosmetic one that's going on. But anyway, I'll talk to you about MF in children. So I see MF both in children and adults. So I run both the clinics for adults and children for cutaneous lymphoma. These are my disclosures. And mostly I'll talk about mycosis fungoides, but I'm also going to talk a little bit about the CD30 lymphoproliferative disorders, because we do see that in some of our pediatric patients. So the cutaneous lymphomas are really a very heterogeneous group of conditions with different clinical, histopathological, immunotypic features, and with variable prognosis. But the good thing in children is that the prognosis of the cutaneous lymphomas tend to be very good. Incidence is still rare. We get maybe about 3 to 5 cases every year in our practice, and the most common would be MF, and every few years we get a case of LYP. The problem is that diagnosis is often delayed. And I think there are studies to show that it takes a few years before a diagnosis of MF is made, especially in children. And that's because it mimics a lot of other types of diseases. And if you don't biopsy, sometimes it's very difficult. And even if you biopsy, sometimes you do miss the diagnosis. So it's very important to have that clinical suspicion and biopsy your patients if you suspect MF, right? So the good thing is prognosis in children is very good. So generally they do pretty well and remain in low stage for many, many years. But we really don't have a lot of data on long-term outcomes of children or adolescents who have MF. So hopefully we can get it over the next few years. The treatment depends on stage of disease, but because most of them are low stage disease, a lot of times they respond very well to skin-directed treatment. That's one of the latest classification, and you can see MF is probably the most common that we see in children, but occasionally we do get a case of CD30 T-cell lymphoproliferative disorder. Most likely, most of the time it's LYP, but the rest of the lymphomas are really very, very rare in children. So MF is the most common. Clinically, we do have patients, especially those in the adolescent age group, with a bit more classical type of MF, where they get these patches. But more often, we do see the hypopigmented form, especially in our darker skin patients. And you can see here, most times they like to affect the areas of the body that are sun-covered, but if it's more extensive, it can go even to the sun-exposed sites as well. Generally, I would say they do have big patches of hypopigmentation. So if you see big patches of hypopigmentation, especially over sun-covered sites, think whether this is MF, especially if this has been going on for months and really not responding to treatment. The buttock is probably the best area to see because that's the area that is the most covered. So I always check that. You know, we have a lot of patients that come in for pityriasis alba. Now I always check the areas that are covered to look for lesions in those areas, okay? Sometimes they may not have big patches and smaller patches sometimes, but you can see here very, very extensive involvement of the trunk, but also on the sun-exposed sites as well. Sometimes they may present with very, very small hypopigmentation, so always suspect that. The other differential is pityriasis lichenoides, which also gives you very small hypopigmentation, especially in our pigmented races. This is a case of a PL-like MF, so we're not too certain really what's this association between PL and MF. We know that there are reports that say that some patients with PL can go on to develop MF, but I think it's probably MF to begin with. They present with PL-like lesions, but you know, when you biopsy, you don't catch it, or sometimes because in kids you don't biopsy that often, and you may not see the MF when they present at this stage. But it's important, to follow them up. This was a case that you can see when he was younger, he presented more with PL lesions, and as he got a little bit older, into teenage years, you can see he's getting much more patches, and here, more classical kind of patches that we see in adult age group with MF, all right? So always patients with PL, if they do develop larger patches, think whether this is a PL like MF. And that is very well reported in children. This was adolescent, so as they go into more adolescent age group, they get more of these patches, very indistinct patches. The edges are not very well demarcated, pinkish, but this patient also had a tumor stage MF on his knee. So other rare forms that we have seen include follicular type MF, where it's more, where you see this follicular accentuation, the hyperpigmented type of MF. Poikiloderma is actually quite rare in children, but sometimes we see solitary lesion. This patient just presented to us a few weeks ago with just this one lesion on his trunk, which was hypopigmented, and then over time, it got bigger and bigger. It really didn't resolve with treatment, all right? So solitary MF can be seen. So what are the differential diagnoses? The most common would be atopic dermatitis with post-inflammatory hypopigmentation, especially in our pigmented children. And you can see here the patient actually has AD with this post-inflammatory hypopigmentation, but we have picked up patients who had eczema and then later on developed MF as well. So that's something that you have to keep in mind, if you see that the hypopigmentation is getting worse. Of course, psoriasis, so we get a lot of biopsies of patients with, let's say, gutted psoriasis, and it leaves that hypopigmentation as well, and then we get biopsies. Pityriasis lichenoides, we talked about this. And finally, tinea versicolor, and the one on the face, pityriasis alba, a lot of times can be a differential as well. Okay, so biopsies are very important whenever we want to diagnose MF, all right? So generally, I would take 2 biopsies, one from a covered area and one maybe less covered. I usually would take one from a hypopigmented area. If there's a scaly area, I take one from there as well, all right? So because in children, it's usually very low stage MF, so you can see mostly patches, and the most common change that we see is really these lymphocytes that tag at the base of the epidermis, as you can see here. Some of them, very often they lie in these vacuoles. Very important sign also is that usually there's very, very little spongiosis. If there's spongiosis there, there's a reason why these lymphocytes are there. If there's no spongiosis, these lymphocytes are abnormal and they lie in these vacuoles, sometimes in 3 or 4 lymphocytes within the same vacuole that we call Portier's microabscess. And you can see here very nicely these vacuolated lymphocytes, usually small to medium size. You don't see large lymphocytes in pediatric MF, and they sort of tag the base. You can see sometimes they go around the acrosyringium as well as the hair follicles as well. In adults, when there is follicular tropism, the prognosis is not so good, but in children, it really doesn't change the prognosis even if you have follicular tropism. And you can see here the follicular tropism around the hair follicle and the syringotropism around the opening of the sweat glands, all right? So very rarely, sometimes you may see plaque stage or tumor stage in children, and this is when you get more infiltrates down into the dermis, sometimes even down into the subcutaneous fat, and you will often still see the epidermotropic lymphocytes there, all right? Immunohistochemistry is mainly supportive, but sometimes we do it to check. Most, they will all be CD3 positive. Most will be CD4, sometimes more CD8, sometimes both CD4 and CD8, sometimes both negative. If you take a few biopsies, you can see that in all the biopsies, they have the same immunostain, and that's a good sign of the chronicity of MF, all right? Rarely, especially in slightly more advanced stage, you may see reduced staining. I find CD7 is often the first one to be lost, but sometimes also CD5 as well as CD2, but we hardly do it in children. So what the pathological features, this was a paper that we've done. Generally, you would see more lymphocytes at the basal epidermis and going up into the epidermis as well, so that's the epidermotropism. They are generally small to medium, and they have these halos around the lymphocytes. Right. So in terms of staging, the good thing is, I would say 95 to 99% of patients, pediatric patients with MF tend to have early stage MF. So when they are stage 1 to 2A, you don't really need to do staging. I just do a very good clinical examination, check on the symptoms, general symptoms as well. However, rarely if you get a stage 2B and above, especially when there's a tumor stage, you do need to stage these patients, and we manage together with our oncologist. In terms of treatment, so most patients, pediatric patients with MF have early stage MF, so either 1A, 1B, or 2A, and they do respond to skin-directed treatments. So generally, if it's a very solitary lesion, you can try to do topical steroids or calcineurin inhibitors. Topical retinoids, we've also used that, tretinoin, bexarotene, or tazarotene. Some people have tried topical nitrogen mustard. I think it's available again. We have not used it in Singapore, but a lot of patients will respond to phototherapy, and that's usually our first line of treatment. In more advanced disease, this is only in case reports because it's very rare in children. You may need to go on to oral treatment, such as with oral retinoids, methotrexate, interferon, and if it's a localized tumor, you may subject them to radiotherapy, all right? Some of the newer monoclonal antibodies like mogamulizumab, brentuximab, they have not been evaluated in children. They are mostly used in adults. Very, very rarely in adults, they may need chemotherapy or bone marrow transplant, but we have not done that in our kids. So this was a study that we did looking at our children. We had 46 patients, and you can see that they present usually after almost 2 years of symptoms before they're diagnosed. Most patients are low stage, so 1A, 1B, or 2A, and they do respond to topicals. Most of them underwent narrowband ultraviolet B, but very few patients, those with more plaque stage, we can try PUVA or UVA1. And you can see that half of the patients will have complete clearance, but there is a risk of recurrence. So a lot of these patients recur, so it's very important to follow them up, as they grow older. Some of them may have partial clearance, but the good thing is, even with long-term follow-up, they don't usually get extracutaneous progression if you maintain them at the low stages, all right? This was another study that we did looking at our patients who underwent phototherapy, and we find that 80% attain a complete response, but only 30% had sustained remission, so it's important to follow them up. Sometimes after a few years, it can come back again. So we usually start full-body narrowband. Even though the lesions may be limited, we like to shine them all over because some of these cells may be there, even though clinically you don't see it, all right? We usually start depending on the Fitzpatrick skin type, so between 300 to 500 millijoules per cm squared. I usually do for at least 6 to 12 months, sometimes moving the dosage up to 3,000 millijoules. Once most of the lesions go away and there's just very few left, sometimes we teach them how to do home phototherapy, so we get them to buy this home phototherapy treatment, and they will do it at home for these residual lesions, or you can add on a topical as well. All right, if thicker lesions, you can consider either PUVA or UVA1. These are just some photos of clearance of the hypopigmented MF after 6 months of treatment with phototherapy. All right. So I think in terms of quality of life, most patients with MF, the patients are not really very affected. It's usually the parents, and it's something that is important when you are talking to parents about a diagnosis of MF. You really have to break it to them quite gently because it is still a type of cancer, and you have to tell them that they need follow-up for life. All right. Okay. So I do find that quality of life in eczema patients is far worse than in MF patients, all right? Okay, so just moving on to the CD30 positive lymphoproliferative disorders. This is the second most common form of T-cell lymphomas in children. And then we do know that it's a spectrum from the ALCL or anaplastic large cell lymphoma to lymphomatoid papulosis, and some of them may have lesions of both ALCL as well as lymphomatoid papulosis. So this is rare in children, very rare case reports where they present with a large tumor that ulcerates at the center, and these don't tend to heal up. Some of these patients may have MF as well, but more commonly we see lymphomatoid papulosis, so they get these self-healing papules. The differential is always PLEVA or even discal eczema, but importantly is that they heal up with scarring. So if you see this in PLEVA, you don't see the scarring, but in LYP, you see quite severe atrophic scarring. So that's a very good sign to differentiate the two conditions. And it can run a protracted course, so we do see patients that have it for years. Pruritus can be a feature, all right, but generally, and also they can occur with other lymphomas. So we have patients with MF that also have LYP lesions. And you can see here it starts with a papule. It ulcerates on its own over a few weeks, and then slowly heals up, and it leaves some scarring, atrophic scarring. And this girl, you can see very nicely, lots of atrophic scars, some ulcerated lesions as well, very, very extensive, all right? And then, of course, you take a biopsy to diagnose, and you see this infiltrate of large cells there that are positive when you stain up to these large cells, all right? These are the LYP cells, and if you stain up with CD30, it stains up quite nicely. And you can see here, they are all CD30 positive cells. But generally, LYP in children still has a very excellent prognosis. So some may self-resolve, but if you need to treat, if it's very few lesions, you can do topicals, so topical corticosteroids. Phototherapy works pretty well as well, especially those with more extensive lesions. But you have to tell patients that they may take 6 to 12 months, sometimes even longer, while on phototherapy. We do sometimes give oral antibiotics like erythromycin, but generally I do try to combine them with phototherapy as well. And low-dose oral methotrexate is another option if these others do not work. And importantly, is to monitor for secondary lymphomas, especially MF, all right? Okay, so in conclusion, MF is probably the most common cutaneous lymphoma in pediatric patients, but most important is that there are many mimickers. So you have to recognize it, have that suspicion in your mind, and if you need to, biopsy. If you take a biopsy and it doesn't show, you follow. 6 months, a year later, you suspect more, you take another biopsy, all right? So it's important to try to catch them, you know, if it progresses, all right? So biopsies are essential to clinch the diagnosis, and the good thing is prognosis of MF in children is generally good and only requires skin-directed treatment. However, we don't have very long-term data on the prognosis of MF as they go into adulthood. We are trying to set up a registry, a worldwide registry for this, all right? So in addition to Dr. Atinanda's introduction of the ISPD, one reason why I'm here is to talk about the ASPD, which is the Asian Society of Pediatric Dermatology. So we set this up about 5 to 6 years ago. We have a lot of members, mostly in the Southeast Asian region, but also India as well. And now we're trying to reach out to the Gulf area for you to join us. So those of you who are very interested in pediatric dermatology, which should be everyone here since you're at this symposium, please join. Membership is free. You can just go on our website, right? Or you can scan this, all right? But importantly, membership is free. We do have a lot of teaching, education, outreach as well. And we even have our own journal, the AJPD. And of course, ISPD. Okay, RT has the more updated one. We now have more than 1,400 doctors in ISPD. Membership is free. All right, so do join us, all right? Go onto our website. It's very easy to join. We have a lot of teaching as well. And finally, hopefully I'll see most of you in Buenos Aires in 3 to 4 months' time. I'm sure it's easier to fly to Argentina from here than from Singapore. So hopefully I'll see more of you there, all right? And with that, I want to, we have our textbook of Atlas of Pediatric Dermatology in Asian Skin. We do have a discount code there if you can, and you can get a 20% discount. And with that, I would like to thank you for your kind invitation to come, for me to come here to speak, and thank you for your...
Thank you.
Yeah, thank you.
Thank you for a nice presentation. So we are at the end of the session, so we can invite all the speakers for any questions. So for the sake of the time, we need one question to each speaker, please. Dr. Abdullah, Dr. Mark, Dr. Anandi. So any question? Dr. Nisha?
Good afternoon. Sorry. I have a question for Dr. Mark.
Yes.
In patients that you are treating for MF, after how long do you monitor the response to treatment, and how do you monitor? Do you perform a skin biopsy later on to see that they have responded or not?
Very, very good question. So generally, you can follow them clinically. So as you do the phototherapy, you find that the lesions, the color comes back very, very slowly. Usually, I will see them every 2 to 3 months, and you can see the color coming back. In a few patients, when the color doesn't come back and they still have lesions, we sometimes may take biopsy to check whether the abnormal cells are still there. But generally, you can follow them clinically.
So any other question?
I have a question for you. Okay. So you mentioned about the topical treatment, for example, and phototherapy. Then you're going to go to shift to systemic therapy as isotretinoin and methotrexate. What do you prefer, and how long do you put the patient on before you switch to another systemic therapy?
Thank you for the question. Again, very important. So generally, I would say I would treat the patient for at least 3 to 6 months on phototherapy first to see the response. If 3 to 6 months, usually at about 6 months, and you find that, maybe there's only 20% improvement, 30% improvement, that's when you think whether you need to add on systemic therapy. So methotrexate, one of the retinoids as well. I do prefer the retinoids because it's easier and there's less immunosuppression. Yeah.
Any other question?
Yes. Hello, hi. Thank you everyone for your lovely talks. I have a question for Dr. RT. Just regarding the skin biopsy versus the genetic testing. My question always is, why do we expose the patient to skin punch biopsies when the genetic testing is more accurate, and the biopsy would just cause more trauma to the skin when the skin is already traumatic, and putting them through that? So just the indication for the skin punch biopsy.
It's an interesting question. Yeah. Earlier we used to, as I said, we used to do electron microscopy, which was much more even tedious to find a good electron microscopist. But now we are it's important to do screening sometimes because we filter the genes. If we know that from immunofluorescent antigen mapping, one of the biopsy is not fluorescing against one particular gene protein, that means most likely it is the gene which is responsible. It saves your cost. You can straightway go for the Sanger sequencing of that gene and confirm in the family. Sometimes it is reduced in dominant mutations or in mild mutations, and still you can suspect. And because otherwise we put the whole panel. And sometimes it may not be much time consuming, but definitely a little more costing for this rather than doing single gene for Sanger sequencing. And RNGS, yeah, but it does give very quick screening. Say, for example, particularly in the countries where they don't have all these facilities available, probably you can start filtering till the time you send your blood sample to the concerned lab. But this is what geneticists tell us always. If you make our life easier, if you filter the case and tell us. Maybe Mark has something to say because he's doing panel in his country.
Yeah, so in the past, we used to do quite a bit of immunofluorescence mapping for the skin biopsies. But over the years, we are using less of it because genetic testing is now so easily done. So the only scenario that we will do the skin biopsy for immunofluorescence mapping is usually a severe case at birth, because the genetic test may take about 2 to 4 weeks to come back, whereas the immunofluorescence mapping, I do it in-house because I'm a pathologist as well. So I read it, and within 2 days, I'm able to tell the parent, your child is going to survive, your child is not going to survive. And then we move into, a supportive mode or palliative mode if, we find that it's Hurlitz's type of junctional EB.
It's a quick answer. answer to our patients, quick answer to our patients actually. Still we are waiting for the results of genetic testing.
So any other question?
Yeah, okay, my question for Dr. Arti. Dr. Arti, how can genetic study will help the family in the future as in case of AB with pyloric atresia?
Overall, when we know the genetic test, we can always do a proper counseling. We can tell them, is it a dominant, it is recessive, which type of disease, because we know that both type of inheritance exist except for junctional type, where always autosomal recessive. We can give the proper teaching about, and then now we also have, EB is the only disease, although it is progressing in ichthyosis also, where we have proper phenotypic-genotypic correlation. So if we know the type of mutation, we can even tell them for prognosis in the future, how bad the disease is going, because this is another question. Will my disease, baby's disease will be throughout life this, or will it improve with the time? So we know that certain genes, what is the phenotype in future? So we can give them that phenotypic-genotypic correlation that your child has likelihood of improvement. And third, in addition to confirmation, third, as I told you, for their future genetic planning. If we have, most of the time we are getting young couples with first or second baby affected, and they want to know, because if it's a recessive, 1 in 4, it's dominant, we don't know, multiple babies can be subsequently affected. So we can, by this, refer them for IVF pregnancy, where they do pre-genetic testing. They have an 8-cell embryo is there. You can test from the 8-cell embryo the gene mutation. So if there are 10 embryos or 15 embryos, you test for those embryos. If those embryos which do not show the gene, which you know already, because if you don't know, we don't know what to test. So those embryos, healthy embryos, can be transferred to mom, so that we have a future hope of having normal and healthy babies. So there are,
Thank you, Dr.
I have a question to Dr. Abdullah. So thank you so much for your very nice cases that you present. So you mentioned in the morphia case, the case presentation, if there is atorvastatin topical available by name in KSA or not, or it's compounding pharmacy. And do you think that topical JAK that will be approved soon for cases of chronic hand eczema will play a role in treating some inflammatory conditions that we don't have a solution for it, like morphia that you present, or some other inflammatory condition can help in this treatment?
Yeah, but I mentioned the atorvastatin for the porokeratosis, not for the morphia.
The porokeratosis,
yeah. For the porokeratosis, yes, we have it. So for the porokeratosis,
you have it by name?
Yes, we have it by molecule. Okay. And the second question for the morphia, we're still on the patient is on the classic treatment as topicals and phototherapy for now. That's mostly it. Mm-hmm. So I need a new topical anti-JAK, still didn't use it. Still in the market, in the pipeline, but hopefully we will have it. The patient still is on remission, he's good, he's fine. Hopefully we won't be needing anything new. But in regard to your question, yes, we know that there's new topical anti-JAK. I did not use it yet, so that's okay.
Thank you. So no other questions, so we can close the session. Thank you so much for your nice presentation.